The surgical experience.
My name's Kevin Gillian. I'm a general surgeon in Northern Virginia. I'm in private practice. I've been primarily a laparoscopic surgeon in my career, in my private practice. I did a fellowship in laparoscopic surgery back in 1998. I've been training for a number of companies, including Davol, ever since. When I decide what type of mesh I use, or the meshes that I use in these laparoscopic repairs, a lot of it has to do with how easy is it for me to use. If I have to do something cumbersome that requires the assistance of a surgical assistant or a second surgeon to do the repair, that to me is a negative. I want something that's simple. I need a mesh that does not require sutures to hold it in the air, that does not require an extra assistant in the field. I should be able to control the whole case myself. I want my assistant to just be holding the camera while I manipulate the field and manipulate the mesh. The EX mesh allows me to do that. I don't need sutures to hold it in place. I'm able to manipulate it with 5mm instruments no matter what size I'm using. I'm able to get it down to trocar sites easily or through the small and skin incisions for direct insertion. With respect to how it is incorporated, that is something that I find interesting. I find that people get into discussions about whether they need to suture mesh or not suture mesh to the abdominal wall. And what they lose track of is it is not a suture issue. It is a mesh related phenomenon. It's a mesh specific need. When you have a mesh like composites that's got a backing of polypropylene, we all know as general surgeons that that gets excellent ingrowth, very reproducible, solid ingrowth. That mesh is not going to go anywhere after it is seated and we've had tissue ingrowth. When you have a mesh that's strictly PTFE based, you do not get the type of ingrowth and you do not see a progression of that ingrowth over time. It's basically reaches a point where it stops getting ingrowth and it never reaches a point where it is as strongly bonded to the abdominal wall as a polypropylene based mesh like the Composites EX. So I don't need sutures to hold it up in the air while I'm applying it to the abdominal wall, and I don't need sutures to hold it long term because we get such nice ingrowth on this particular mesh. I also don't have concerns about this mesh dissolving or weakening over time. It's a permanent mesh. It has a surface that is friendly to the viscera, that's not going to cause fistula formation. We don't see fistula formation long term with PTFE coated meshes. So there's an advantage. And then you have the handling aspects of this mesh, which is, again, I can do it all myself. No one's suspending it with sutures. I can put almost all of these sizes through a trocar. The largest ones have to go through the abdominal wall, but they're easily handled, easily placed, manipulated with 5mm instruments. It's a non-cumbersome technique that's easily learned by all surgeons. With respect to seroma formation, if you look at these patients under ultrasound, 100% of them have a seroma of some type. That's expected. That would not be an unexpected finding. The most important thing is how do you prevent clinically significant seromas. I put an abdominal binder on my patients. They know that going into surgery. They know they have to wear it for a week after surgery. If you do that, if you look at the literature, you're going to reduce your clinically significant seroma rate by 50%. I do over 100 of these operations a year. I probably aspirate less than 1 or 2 people per year in my office for significant seromas. When I pick a mesh to cover a defect, all I'm concerned about is the overlap. I want a 5cm overlap in all dimensions. The shape of the mesh absolutely is not the critical factor. I'm more concerned about the overlap. There are so many varieties of mesh available that I can accomplish this with what I keep stocked in my OR. If the mesh is a little bit too big, I don't cut it down. I just take a few extra centimeters of overlap. There's no problem with that. I certainly would rather have a little extra mesh than not enough and perhaps suffer a recurrence because the mesh is too short on one side.